Good afternoon, everyone.
Good afternoon.
Thank you all for joining us today for the first Health Outcomes Seminar Series for the spring semester. As you all know, the seminar series is sponsored by the Center for Pharmacoepidemiology and Economic Research. Today is my true pleasure to welcome one of our own faculty members and colleagues, Dr. Greg Calip, who's an assistant professor in the Department of Pharmacy Systems, Outcomes, and Policy, and also an affiliate member in CPR. Dr. Calip, as many of you know, is an alumnus of the UIC College of Pharmacy, where he received his Doctor of Pharmacy degree. Then he received his Master in Public Health in Biostatistics and Epidemiology from New York University, and a PhD in epidemiology from University of Washington. Then this was not enough training, then this was followed by a postdoctoral fellowship at the Fred Hutchinson Cancer Center in Seattle with a focus in cancer epidemiology and prevention. Dr. Calip's primary research interests relate to the influences of commonly used medications and comorbidity on cancer risk and outcomes among cancer survivors. And I'm also pleased to share with you that Dr. Calip has recently been awarded an R21 grant from NHLBI, the focus of which is to study racial differences in cancer treatment-related cardiotoxicity. So with that, please help me welcome Dr. Calip.
All right, thank you very much, Edith, for that really kind introduction. I'm really glad to be here. So today I'm going to be talking about causal inference methods, specifically causal mediation analysis, and its use in understanding socioeconomic factors and cancer health disparities. And I'm going to be presenting that in terms of research that we did here in our department, where we're looking at racial differences in the treatment of DLBCL, or diffuse large B-cell lymphoma. Okay, so as always, first, I have no direct conflict of interest to disclose for this presentation, but I am supported by the CCTS as an affiliate scholar in their CAT Scholars Program. I have funding as an investigator on grants from AHRQ and NIH, and also from AbbVie in a collaborative fellowship with our departments. Obviously, this content is my responsibility and the responsibility of my co-authors, but does not represent that of the official views of the funders. And this was actually previously presented in part at the ASH meeting in 2016. So I really need to acknowledge some of my colleagues here in the department that have really helped push this project forward, specifically two of our PhD students, Jenny Guadamus and Katie Ozenberger. They really drove this analysis forward and are the co-first authors on the paper that's under review. And then I have several other colleagues here in the College of Medicine and at Boston University and the University of Chicago that really made this data available. And finally, this study uses the SEER Medicare Link database, and we fully acknowledge the efforts and hard work that it took for all of the cancer registries and the IMS services to collect this data and make it available for us for research. Okay, great. So today I'm going to be talking about the motivations for studying mediation in epidemiology. I'm going to go over some of the traditional epidemiologic approaches to mediation, give some examples, and talk about some of the limitations of those traditional approaches. I'm going to talk about causal mediation analysis in terms of causal inference methods, give some counterfactual definitions and some of the assumptions that are made with those methods. We're going to bring this toward the discussion about socioeconomic mediators of cancer health disparities, and specifically in DLBCL. And then finally, look at some of the policy implications from using mediation analysis in cancer health disparities. So I'm really excited to talk about this topic. My students know that these are the areas that I really like the most: causal inference methods, or epi methods, and cancer health disparities. Each of these different points in the outline could be a lecture on its own. And I know that we're a diverse group of health outcomes and health services researchers and researchers in the social sciences. So I'm going to assume at least only a base understanding of kind of causal methods in epidemiology, or causality. I know that a lot of us have that background, but not always an advanced level. So I'm going to give kind of a broad overview at looking at these methods and I'll avoid using excess formulas or regression equations. I know that from lecturing to students that when I put too many of those on the screen, I feel this universal like eye roll and groan coming from the audience. But talking about it more broadly, I'm also hoping to kind of demystify some of these advanced methods if you haven't encountered them before, or if you are already using them. They're becoming more and more readily available to use with software packages in R and SAS and Stata. So, all right, let's get started. So why are we interested in mediation? So in multiple research contexts, we may be interested in the extent to which the effect of an exposure A is influencing an outcome Y, and the extent that that's mediated by some intermediate variable M. So in other words, we're interested in what are the direct and indirect effects of exposure on an outcome. So let's give a quick example. So in 2008, there were 3 GWAS studies that identified this variant on chromosome 15q25 and then related it to increased risk of lung cancer. So those same variants were also demonstrated to be associated with smoking behavior as average cigarettes per day and also nicotine dependence. So it was unclear whether the effect of these variants on lung cancer was direct, acting directly through some biological pathway, or if it acted indirectly by influencing smoking behavior and thus increasing lung cancer risk. So among the 3 studies, there were conflicting findings. 2 of them suggested that the association was direct, and the other suggested that it acted primarily through this mediated pathway of nicotine dependence. So what are the standard approaches that we take to mediation analysis in epidemiology and social science research? So first, what we do typically in this causal diagram, we would first regress the outcome on the exposure A and measured confounding factor C, and we would obtain an estimate that's adjusted for confounding factors. Then we'd compare that estimate of phi1 to exposure A with the estimate of theta1, and here we would have a model that includes the mediator. So we've looked for the adjusted effect of exposure, and then also included the mediator in the model. And so if these 2 coefficients differ, the usual measures of direct and indirect effect would lead us to believe that some of this effect is mediated. So that direct effect, which is theta1, would be the association that we measure here, perhaps this controlled direct effect, where we've blocked this pathway of the mediator. And the indirect effect would be that difference between that overall effect and the effect that we've found from that direct effect. So let's look at a quick example of this as well. So in this paper in 2008 in the American Journal of Epidemiology, they were looking, the authors were investigating the extent to which cumulative lead dose, A, the exposure, affected cognitive function, Y, the outcome, and how much that was mediated by brain volume. So again, that standard approach, we're going to regress the outcome Y on exposure A and the confounding factor C, and then we want to consider whether that coefficient changes when we include the mediator in the outcome. So when they controlled just for other factors, the confounding factors that they measured, they found that the overall effect of lead dose was a 5-point decline in cognitive functioning. So when control was also made for the mediator, brain volumes, the estimate of the direct effect of the exposure became a decline of 3.79 points. So because the effect decreases from 5 to 3.79, we could give this measure of the indirect effect as 1.21, which was statistically significant. So how we sometimes refer to this in epidemiology and in the social sciences is the difference method or product method. So what are one of the things that's kind of flawed with this approach, these traditional epi approaches in looking at mediators? So in a lot of biomedical and epi studies, we give really careful thought to what are the confounding factors between the exposure and the outcome. And that's C1 here in this diagram. However, often little thought is given to collecting data on the variables that could confound this relationship between the mediator and the outcome. So mediation analyses are often secondary analyses in a lot of research, and these variables often aren't controlled for. So just as unmeasured exposure outcome confounders can generate bias in these estimates of overall effects, so also can unmeasured mediator outcome confounders generate bias in the estimates of the direct and indirect effects that we're interested in. So there are two approaches that can be used to address this mediator outcome confounding, and ideally both would be used. In the study design phase, we'd want to look at, if we're planning to do a mediation analysis, give careful thought to collecting data on the mediator outcome confounding variables. And then also after the study's finished, if there's unmeasured mediator outcome confounders, then we can use other techniques that we use in epidemiology, such as sensitivity analyses like probabilistic bias analysis that can look at the effect that a certain mediator outcome confounder could play in invalidating inferences about direct and indirect effects. So ideally, both of those would be used. Often neither is used.
Dr. Calip, only because you so graciously said you make it at baseline, presuming people in here don't have as much knowledge, and don't go back to it, but just so we understand why this is necessary for that 1.21 for that other study. So what's the effect on the interpretation of the big outcome?
So when we'd be looking at that, so if it, so say there were two options for interpreting the conclusions from that study. If one could be screening for that variant on that chromosome, then that would be one approach to trying to prevent or anticipate higher risk in some folks for lung cancer. If the pathway is mainly through nicotine dependence or smoking behavior, then maybe it's better and motivated to use public health efforts to address smoking. So that would lead us down two paths and maybe refine some kind of intervention that we could do.
Thank you. For our students, that's a somewhat test to see how well he did that.
I anticipated that. If anyone was going to do that, it would be Stephanie. Thank you. So some quick definitions for what we'll be talking about in the rest of the lecture. We're going to be talking about a controlled direct effect. So that's looking in that regression where we've looking at this controlled direct effect comparing treatment or exposure level A1 to A0, so exposed to unexposed after fixing M. So there's potentially in this kind of controlled direct effect a different level of M. So for the presence or absence of the mediator, there could be a different direct effect. The natural direct effect would be comparing the exposure level 1 to no exposure with the mediator set to what it would have been if the treatment had been absent. So the way to maybe think about that is that the natural direct effect is choosing one of those two controlled direct effects. It's choosing the one where the mediator would be gone and not in the presence of the mediator, or the mediator is the reference category. The natural indirect effect is meaning that we are looking to fix treatment to A1 exposure and then comparing the effects if the distribution of the mediator were set to what it would have been with treatment versus without. So we'll go into that a little bit further. In order to estimate these direct and indirect effects, we need to make multiple assumptions here. The first is that there's no unmeasured exposure outcome confounders, so C1. There's no unmeasured mediator outcome confounders. There are no unmeasured exposure mediator confounders given C, and there's no mediator outcome confounder, meaning that there's no arrow from A to C2. So what we know is that for a randomized trial, when the treatment is randomized, we guarantee 1 in 3. For the controlled direct effects, we only need these assumptions of 1 and 2, and we've understood from that last kind of slide where we looked at whether or not we can plan for collecting information on confounders or using sensitivity analysis, we can kind of overcome some of these others. And so these are pretty strong assumptions, but we can work with them. So what's another measure in causal mediation analysis that's important? So what we can do if we find a total effect is that we can look at the proportion mediated. And this is really answering that question, how much of this effect is mediated? And it can be measured as the proportion mediated as the natural indirect effect over the total effect. And then if we can also look at the proportion eliminated, which is another kind of way to look at it. These typically coincide in the absence of interaction, but this would tell us what proportion of the effect would be eliminated if we fix the mediator to a specific level. So the proportion eliminated is a little bit more relevant for looking at policy. What if we could fix or intervene on the mediator, make something equal for all of the population? What would that do to this health outcome? And then also proportion mediated is relevant for etiology. So looking at it that way, how much of this effect works through this particular pathway? So it helps us have this better understanding of the relationship. So again, when we're looking at regression for causal mediation analysis, if we can assume these four things, assumptions 1 through 4, we can do two separate regressions. So one regressing the outcome on the exposure, mediator, and measured confounders, and then also regressing the mediator on the exposure and the confounders that we have. These regressions are combined to estimate these natural direct and indirect effects, and we can use these regressions to also maybe accommodate exposure-mediator interaction. That is a whole separate lecture where we're talking about interaction. We'll largely be assuming that interaction is not present. You can test for it in some of the methods, but in our study, we did not find evidence of interaction. Again, a separate discussion, perhaps a whole other hour in itself. Okay, so again, to summarize these motivations for studying mediation, it can increase our scientific understanding and explanation. So the example that Stephanie and I were discussing, how do these genetic variants affect lung cancer? Is it better to maybe intervene on smoking behavior, or is it something else biological that we can screen for? It can help us confirm or refute hypotheses. So does something like early life socioeconomic status affect adult health principally by setting this economic trajectory? So is that typically how what we're measuring is affecting what the outcome is we're looking at? We could limit the effects of exposure by intervening on a mediator. So can we eliminate the effects of antipsychotic clozapine on mortality through increased agranulocytosis by having some plan to monitor for ANC and address leukopenia early as pharmacists and other clinicians? And finally, we can refine interventions. So we can improve components of an intervention that best target a mechanism. We can eliminate maybe costly, ineffective components of an intervention, and also perhaps understand why in a clinical trial or a larger cohort study, why an intervention failed. So in summary, the standard approaches to mediation analysis are subject to the problems of unmeasured mediator confounding and the assumption of no interactions, but we can work with these assumptions and still perform some of these analyses post hoc, or hopefully if we can plan for them ahead of time, collect information on these. Either of these problems can give rise to paradoxical results, as we saw in the first example, and from the causal inference literature, we now have this provided counterfactual definitions of direct and indirect effects that can generalize methods from mediation methods in the social sciences to that in epidemiology and make clear and more precise some of the assumptions that we make for a causal interpretation. So I'm going to talk about this in the setting of a study that we did here in our department. And again, these are the other authors of the study here, and this paper is currently under review, and also what we presented at the ASH meeting. But I really want to credit them with a lot of work, and especially the two co-first authors who are PhD students in our department. So I'm going to be talking about about racial differences in the treatment of elderly diffuse large B-cell lymphoma. DLBCL is the most common non-Hodgkin lymphoma subtype, and so among folks over age 70, this accounts for 40% of the NHL subtypes. So it's largely the most common. Increased survival with the introduction of really highly effective therapy in the last 20 years has really advanced survival, and this would be the advent of rituximab plus standard chemotherapy regimens. So R-CHOP, which is rituximab plus cyclophosphamide, doxorubicin, vincristine, and prednisone. We know that there are differences in DLBCL by race. Black and Hispanic patients tend to be diagnosed at higher stages of disease. And although Black patients have lower overall incidence, they tend to present at younger ages, more often with B symptoms indicating a higher severity of disease, and experience higher rates of mortality compared to other races. And among the elderly, they are less likely to receive treatment with chemoimmunotherapy and more often receive watchful waiting or observation. So in a previous study in 2010, they found that DLBCL 5-year relative survival rates were lower among Black patients. And then when they did a Cox proportional hazards regression to account for, one, the different amounts of treatment that were received by Black patients versus white patients, and two, some socioeconomic measures, when they were initially first seeing a disparity where there was higher rates of mortality in Black patients, this nullified the results. So what do we take from there? On one hand, we could conclude that Black patients compared to white patients have no difference in mortality after you've adjusted for SES and differences in treatment. What that kind of leaves behind is if we've essentially kind of blocked that mediator in the pathway, which is either SES or something else happening in the racial differences, we kind of leave behind that there is a reality of true socioeconomic differences and disparities to access medication that might make this an unequal benefit from this breakthrough treatment. There are differences in treatment utilization, and there's a known association between health insurance status and DLBCL treatment and survival in younger adults, so ages 18 to 64. And this was done in a study comparing Medicaid and uninsured patients to those with private insurance. And despite the age-eligible health coverage for adults in the older adults in the U.S., these treatment differences still persist among elderly cancer patients. So among elderly white patients, they have higher rates of Medicare private supplementation and lower rates of dual Medicare-Medicaid eligibility. And what we know about this is the lack of private supplementation is related to higher out-of-pocket costs for cancer treatment and a financial toxicity, which is really on the minds of a lot of researchers of cancer treatment, leads to lower adherence to recommended therapies for cancer. So what else do we know about socioeconomic status and DLBCL? So ecologically, geographic barriers can contribute to lack of healthcare access. Medicare beneficiaries, for example, living in rural areas have a 5 to 9 times longer travel distance to receive treatment compared to those in urban areas. And there are other studies in other hematologic malignancies that have looked at SES factors like neighborhood SES and educational attainment, such that those in a lowest quintile of neighborhood SES or those with the lowest educational attainment are less likely to receive chemotherapy and bone marrow transplant, which for many hematologic malignancies is the only curative option, or the best curative option. So the purpose of our study was to conduct causal mediation analyses examining associations between race, ethnicity, and the receipt of chemoimmunotherapy with potential mediation by some SES proxies and variables that we were able to measure in the SEER Medicare linked database. So the first was having Medicare private supplementation. The second was metropolitan statistical area, or MSA, of residents, and the census tract poverty level. So in our study, we set up our own causal diagram. So this exposure A, or the difference between the groups A, was race ethnicity. The mediators included those SES measures here, and the outcome was DLBCL treatment with chemoimmunotherapy. So we also planned ahead of time to try to collect information on what we believe were measured confounders for the race ethnicity and treatment association, and also those between SES and chemoimmunotherapy treatment. And of course, as in any observational study, we can't rule out that there were unmeasured confounders that could be affecting our inference. So this was a retrospective cohort study using SEER Medicare from the years 2001 to 2011. They were first primary DLBCL patients that were 66 years or older. We collected information on treatment and clinical information from claims and registry data, information on Medicare supplementation, and those census tract SES variables. Patients were excluded if they had non-age-related Medicare eligibility, such as end-stage renal disease, if they lacked continuous enrollment in the 12 months prior to and following diagnosis of DLBCL, unless they died. If Medicare was not their primary payer, so this would be the case in the case that someone still has private insurance that's the primary payer and Medicare is the secondary payer, and if they were missing information on the exposure of interest. The measured confounders that we collected were age, gender, the Ann Arbor stage of the lymphoma, year of diagnosis, and the NCI Charlson comorbidity score. So again, looking back really quick on what we talked about before, under the assumptions 1 through 4, we can do these 2 separate regressions. So regressing the outcome on the exposure, the mediator, and confounding variables, and then regressing the mediator on the exposure and the confounding variables. We can combine these estimates and use them to accommodate interaction if that's possible, or if it appears to be present. And we can also figure that in and to calculate the indirect and direct effects. So let's get right to the results. So in our study, we included overall 10,626 patients. And this is stratified by whether or not they received any chemoimmunotherapy and whether they received watchful waiting or observation. So as we can see here, those that had a Medicare with private supplement were more likely to have received treatment than those that did not. There are some modest differences between the groups here that were statistically significant given maybe the fact that these sample sizes are 6,000 and 4,000 in comparison. So slightly more people lived in a big metro area if they received chemoimmunotherapy, and more people lived in census tract poverty levels that were lower if they received chemoimmunotherapy. So looking at the characteristics of these patients by race, we also saw that white patients were the most likely to receive treatment. 58% received chemoimmunotherapy, whereas lower proportions in Black, Asian, and Hispanic patients, lower proportions were treated. We can also see that difference between by race in these SES variables where more white patients had private supplementation of Medicare, whereas lower proportions of Black, Asian, and Hispanic patients, between 40 and 30%, only 30% had private supplementation. Also, the more Black, Asian, and Pacific Islander and Hispanic patients lived in big metro areas, so counties with more than 1 million residing, and then those patients also, Black and Hispanic patients lived more in poverty levels that were greater or equal to 10%. So doing that first regression that we were talking about, when we first did not account for the mediator in that pathway, so looking at the effect of that exposure on the outcome, we saw that compared to white patients, the Black, Asian, and Hispanic patients were less likely to have received chemoimmunotherapy in that first 12 months, so less likely to receive primary treatment. When we then accounted for in a second model that included the mediator, so blocking that mediator pathway, we found that once accounting for private Medicare supplementation, whether that was present or not, nullified that effect. So none of these were statistically significant, and they were similar to white patients in terms of odds to receive chemoimmunotherapy. The same wasn't true of accounting for big metro area or census tract poverty level. For some of them, they became less significant, or one of them nullified here in terms of Black patients compared to white patients in big metro area. But it was really this blocking of the pathway in private Medicare supplement. So if we only took it that far, what we would say there is that there's really no difference between white, Black, Asian, and Hispanic patients in terms of whether they're likely to receive treatment if we've accounted for or adjusted away the fact that different people have different levels of Medicare supplementation or health insurance status. So let's look at this a little bit further in this kind of causal mediation analysis. So looking again at the second regression where we're looking at regressing the mediator on the exposure of interest and adjusting for other confounding factors, we see that Black, Asian, and Hispanic patients were more likely to lack private Medicare supplement. They were also more likely to live in big metro areas, and Black and Hispanic patients were more likely to live in census tract poverty levels of greater than or equal to 10%. So kind of, again, confirming what we saw, but in adjusted models, what we saw in table 2, comparing the different groups by race. But really kind of looking further at this private Medicare supplementation as this one that was a blocked pathway that nullified that effect or that racial disparity or difference. So the other effect measures that we can measure in causal mediation analysis, given what we've looked at so far, are 1, the proportion mediated measure, and 2, the proportion eliminated measure. And in the absence of interaction, these two coincide. And in our study, we actually did not find evidence of significant interaction and didn't include interaction terms in our final models. So after using these estimates to calculate the natural direct, natural indirect, and total effects, we were able to see that with Medicare supplementation, those differences that we saw in treatment, about half of that difference was mediated through whether or not they had private Medicare supplementation. So that was true for Black patients, Asian patients, and Hispanic patients. Little, if null mediated effect occurred through metropolitan statistical area or census tract poverty level. But what we can see here is that a substantial amount of the effect is mediated through this pathway. And for those of us who are familiar with kind of this literature and looking at proportion mediated or eliminated, that's a quite substantial proportion. So oftentimes we see we get excited about maybe 20% mediated, that we've really found this novel pathway. So this is actually quite a substantial amount of difference that's accounted for by looking through that mediated pathway. So what did we see here? So when comparing Black, API, and Hispanic patients to white patients, we saw approximately half of that racial difference was mediated by having or lacking private Medicare supplementation. Our findings were consistent with the available, although limited, literature that showed that differences in DLBCL treatment occurred by racial and ethnic group, and treatment rates among those with less comprehensive insurance coverage are lower. These results are applicable to a large proportion of the elderly population, given that Medicare covers 95% of the elderly population. And given that DLBCL is the highest incidence lymphoma subtype in the elderly, understanding these really substantial mediators to treatment access is critically important to making equitable public health gains from what we know is a highly effective breakthrough treatment, or RCHOP. So why is there this persistence of racial disparities in cancer treatment? So some of our data and the data of others suggest that minority patients continue to experience these barriers to effective treatments. In our data, it showed to some extent to socioeconomic factors, specifically private Medicare supplementation. Treatment of DLBCL with RCHOP regimens is highly efficacious, and we know that, at least from the clinical trial data, that regardless of race ethnicity, these are effective treatments. However, Black and Hispanic patients with both indolent and aggressive NHL subtypes are still less likely to receive this extensive or aggressive treatment in the elderly especially. And beyond cancer treatments, we know that racial disparities persist in cancer due to differences in prevention, screening, and outreach. So kind of across that spectrum, and we've only kind of looked at a snapshot in terms of racial differences in treatment.
Right. So on your first bullet, the impact of insurance, I'm just thinking, going a little deeper and wondering why insurance would, or whether they have private insurance, would make a difference. Are doctors more likely to prescribe therapy if the patient has private insurance? I guess my experience with my parents was, under Medicare, there was never an inclination to hold back treatment. Mm-hmm. So I'm kind of curious what you learned in this.
Right, it is curious, and since DLBCL is an aggressive non-Hodgkin lymphoma, it's typically, especially in younger adults, this emergency, so we need to treat it right away, like other acute lymphoid and lymphoid neoplasms and leukemias. So there's a couple things there. So when we're thinking about elderly, that observation and watchful waiting is absolutely also a feasible option. So it's not like this very inferior option, especially for even older patients that have other issues like frailty or dementia or some other limitations. Then observation is a completely reasonable choice, and that is kind of given patient and caregiver preferences, especially in the very elderly. One part of that decision when deciding to move forward with pretty aggressive treatment, if it was multiple cycles of RCHOP in this instance, would be maybe the cost. So if you lack private supplementation, all of these patients had continuous coverage on Medicare, and so if they lack private supplementation, then the out-of-pocket costs may be higher. That could be one part of that consideration. But it's shocking to see, since these were all continuously covered patients, that there was this much of a difference.
It could be differences in just the inclination to go for more aggressive therapy versus, like you said, observation.
Right. So, and so when not doing like a kind of some deeper mediation analysis to kind of like tease apart what these individual factors could be, and again, we didn't have data on what the patient preferences were, or really advanced information on like functional status or frailty, but kind of teasing out that there are some like larger contributors to what that difference in treatment could be is important. Yeah.
I'm ignorant about if you don't have a regular supplement, is Medicaid always a supplement, or is there a large proportion of people who just don't have the supplemental coverage, period?
So, okay, so the people that have the lowest out-of-pocket coverage that's incurred are those with dual Medicare and Medicaid eligibility that have enrolled. Those with the lowest, then followed by private supplementation, which typically covers a lot of the cost. Those that have only Medicare A and B with or without Medicare Part D prescription drug benefit have the highest out-of-pocket cost to incur. So that's where that would fall. It really varies depending on region, but in this data set, we saw that about 60% of the patients that were in there had some private supplementation, but then that was much lower in Black, Hispanic, and Asian patients. Yeah, so it was between 30 and 40%.
Yeah, so the policy implications are you could improve Medicaid supplementation, but it's not clear from what your data is saying that they were the ones not doing very well, right?
Yeah. So we'll, that's great. We'll talk. We get into it a little bit later, but I'd love to address it. So there's two things that we could do. One way is kind of still working in that old structure where we adjust it for something as a confounder. So maybe we could adjusting for it would. You could say that would mean eliminating private supplementation, and so just everybody has bad coverage, and now there's no longer disparity, right? So there's that. We could make it more equitable to be able to afford some kind of private supplementation. An alternative there could be making the coverage under Medicaid or more available, like the dual Medicare eligibility, or just making that coverage as robust as that's received with private supplementation. So there's a couple different ways to look at that, but it seems much more reasonable the latter two, either making more equitable or affordable private supplementation, or making Medicaid as robust a coverage as private supplementation, or more available. So it's since really the lower out-of-pocket cost comes at Medicaid eligibility. So among our mediators, only the private Medicare supplementation was demonstrated to have an effect on whether patients with DLBCL were treated. But we know that community level and population level SES measures matter, but they only accounted for minimal mediated effects. So further research is needed in this area to kind of tease apart what the detailed geographic data at a more granular level than what we had here, to see if the role of these factors take in relation to racial ethnic disparities in treatment of DLBCL. For other conditions that we know, like coronary heart disease and cardiovascular disease, we know that access to essential medicines is shown to be affected by community-level racial composition. So, to paraphrase one of my co-authors who isn't here, Dee Makedo, what good is a breakthrough treatment if you do not have access to it? I wish she was here to comment on it. She was just in the Chicago Tribune if you didn't catch it. So the policy considerations to think about here are while 5-year mortality has declined for DLBCL over the past 2 decades, in large part due to this kind of breakthrough treatment with rituximab therapy, rituximab plus standard chemotherapy. As with other breakthrough treatments, groups benefit unequally from this advancement. Racial minorities and individuals with no insurance or public insurance have higher rates of watchful waiting and mortality. And according to Phelan and Link, these disparities persist because individuals with higher SES or more resources have greater and more immediate access to these new medical treatments and technologies. And as the field of oncology continues to progress toward precision medicine and really targeted therapies, the potential for this kind of worsening disparity in under-resourced populations is daunting. It would likely increase. So it's necessary to promote policies that improve access to medications regardless of SES to reduce racial ethnic disparities. And so as we talked about, this could be one, improving access to private Medicare supplementation or making some kind of supplementation available. And for individuals who cannot afford a private supplementation, making access to highly effective treatments through either greater Medicaid eligibility or assuring that coverage is comparable to that of private supplementation could be some paths that we have out of this kind of difference that we've established here. So finally, the rising cost of cancer care in the US is something that's of great concern to a lot of public health researchers. By 2020, the cost of cancer care will rise to $137 billion. And the rising costs of cancer treatment and out-of-pocket expenses represent this significant burden to cancer patients and barriers to care, especially for the elderly. In other studies, out-of-pocket expenses for Medicare beneficiaries varies by supplemental insurance, and we know that those that have no supplemental insurance have the highest expenditure. So together with our findings, these other studies also suggest that improving both access and affordability of important cancer treatments may optimize treatment outcomes that we know are possible with these really effective treatments and reduce cancer health disparities in racial ethnic minorities. And while we've only looked at treatment here, it would be interesting to look further at how this affects survival and how this differs by insurance status in the elderly. So there were limitations to our study. In past studies that looked at proportion-mediated estimates, they often found them to be unstable, especially looking at within different mediators at the same time. But with our large sample of patients, over 10,000, we didn't think this was a considerable limitation. Analytically, applying the product or difference method assumes all of those assumptions that we looked at before, assumptions 1 through 4 about confounding and unmeasured confounding. And so while we were able to collect a lot of measures that others could not in other databases, given the absence of randomization and mediator proxy measures, we can't rule out unmeasured confounding. And finally, the generalizability of our findings are possibly limited due to the sampling from SEER reporting regions instead of the entire US, and excluding patients who did not have Medicare as the primary payer. And the reason why we acknowledge that is just in that where SEER regions cover are areas where there is at a minimum an NCCN cancer center, so possibly the level of care is higher, so maybe the disparity is truly more than what we observed. And excluding patients that don't have Medicare as a primary payer or lack continuous coverage is excluding some patients that we're also really interested in, those that aren't able to continue enrollment on Medicare and lack coverage. So in conclusion, understanding health insurance-related disparities in lymphoma treatment and outcomes remains an important concern for oncologists and health policymakers. We found that approximately half of the observed differences in DLBCL treatment by race ethnicity were through this pathway of Medicare supplementation, and still our findings provide important evidence for public health policymakers to consider what we can do to reduce cancer health disparities, particularly in the treatment of hematologic cancers like DLBCL. So I know there are a few other questions, but I'm happy to take them and talk to anyone further about a mediation analysis. And thank you for having me. Sure.
Could you talk about how you tested the interaction and whether that involved a proportional limited measure? That's a little unclear on those two things.
So it's pretty similar to what you do in other, so these were logistic regression models for the outcome of yes treatment and no treatment, and we did some analysis around that, whether it would involve also radiation or not. But for those interaction models, we essentially just included interaction terms that were relating the mediator and the outcome, or the exposure and the outcome, and tested for whether there was evidence of significant interaction that way. We also looked for effect modification in terms of looking at the effects on different levels of the mediator. And while that was true, it didn't look like it was significant. So you can apply still some of those standard epi principles to these regression equations, and I think it's nice that way, and that it makes it really accessible. So we use Stata packages for this. So there's a module that covers both of these kind of in a really straightforward way for you to use them if you want to apply it to your own research. Rachel.
In your experience with the Medicare SEER data and this population and their distribution of cancers, would it be possible to replicate this analysis in another cancer to sort of test the hypothesis that the Medicare supplementation is sort of a persistent mediator and it's not something specific to DLBCL and R-CHOP?
So that would be possible. So we are using some other databases for that type of research. In other cancers, we're looking at, but also using the SEER database without Medicare. We were looking at, now since 2007, SEER collects whether someone has, people of all ages have any insurance or no insurance or private insurance, I think, versus Medicaid. So we were looking at whether or not in breast cancer, for example, having insurance was mediating a pathway for differences in race in terms of breast cancer stage. So the thinking there was that we don't have information on mammography, for example, but maybe that was lacking insurance was a pathway that someone lacked mammography and got detected at a later stage. So there's some other areas where we're looking at this, but it's largely new. And so I hope that other people replicate these findings in other cancers too, and apply to maybe survival as well. Although the methods around using this in a semi-parametric model for like a time to event model aren't fully fleshed out yet. That there's a couple of really good resources on it, but they aren't as well established as looking at kind of a continuous measure or binary measure with logistic regression. Yes?
I wonder if you'd comment on the robustness of the findings given the assumptions. So first off, it's retrospective, so there could be all sorts of selection things that you didn't have time to address.
Mm-hmm.
And then you make 4 heroic assumptions and get to a result that you like. But how concerned should readers be that those assumptions can't be verified very easily?
Yeah, so, and those are strong assumptions, and unmeasured confounding certainly. So the nice thing about using these methods, I guess, in terms of what they have in the statistical packages too, you can use some of the standard sensitivity analyses that you've used. So in our case, we used something like probabilistic bias analysis, so that if there was unmeasured confounding, so for U1 and U2, if there's unmeasured confounding, there's clearly is. It's this retrospective administrative claims database. So what we can do there is establish what these types of confounders would be and vary the strength that they would have to change this, to change like the odds ratios that we had observed. So it would take, for instance, a confounder, a U1 confounder with a relative risk of 6. Or an odds ratio of 6 in order to nullify completely what we observed here. So you can apply some of those methods in simulation to what we did here. Again, that only gives you this look in terms of numbers. So it can only give you that to say within a reasonable range, there could be confounders. It would have to be up to this level for us to completely say that our findings are not, are not robust. So they can only be, using some of the analyses that we have there. But, as with other studies, it's unmeasured confounding is a problem. Yeah.
6 would take it to 0, right? But maybe 4 would take it to negligible.
Sure.
So even there, it's being presented in a way that makes the narrative straightforward.
Yeah.
Greg, can you do the same kind of quantitative bias analysis with U2? And did you do it with U2?
Yes, so you can.
Not the rock group, but the variable.
Yes, so you can implement that and then enter this in simulation, a confounder in both U1 and U2. And it's better if you have a really strong idea of what that confounder is, and you can even place it in the presence of other confounders. Todd knows that I like to do these simulation studies. So yeah, you can put it in the presence of confounders that exist in this relationship and the one here for U2, and have this 3-dimensional table of, it would take an odds ratio of 8 here and 2 there, and to make the result, the proportion mediated or eliminated 0. So
to get at Mike's question, you could presumably even do that with the lower bound of your confidence limit, right? Sort of, here's where we might see the movement of that lower bound of the confidence limit go down to 1.2 or 1.3, something where we're not very confident that it has policy implications.
yeah, and we could make a best guess that there is a certain amount of confounding and then limit, like pull back that proportion mediated 50% to within a bounds of something that, given unmeasured confounding, this is what we'd see. And these are really good points because the reviewers bring them up too. Yes.
Hi, you had mentioned something about if there's a sample size less than 500, it can become unstable. So is it just not recommended if you have a smaller study, or there are techniques that you can employ to deal with that?
So putting the limits around these estimates is difficult. There's a few different methods that are used for it, and I think it comes a lot from the social science literature, where we see these kind of unstable estimates and that change with some small with even a small difference in measurement. So those were with studies that were far lower than 500. So it's just having the confidence around that. And so in this case, a lot of our estimates were robust to including and excluding and where we needed to. So we didn't see a lot of change. So while we didn't present limits around them here, they remained rather stable. And
so you can do it. You just need to be conscious of.
Yeah. So. And 500 is really an arbitrary kind of number to put out there, but in some of the previous studies where they did expect it to be, where they did find substantial difference by making some even measurement changes, they found substantial differences in the proportion mediated and estimated or eliminated effect, especially. Yes?
I'm still struck by the policy implications, because what this really means is a universal health thing wouldn't solve the problem, because Medicaid doesn't help. Am I interpreting this correctly?
Well, I would offer, so I did sell this as this, like, oh, there's a policy interpretation. You can intervene or fix or eliminate some kind of difference there, and then hopefully resolve this disparity or difference in treatment by race, ethnicity. It's still hypothesis generating, so the fix to that isn't immediately clear. I mean, again, the one from the treating it as a confounder says that make it equal across all, and so that's less helpful. That could mean, removing everybody's coverage and everyone's just, out of luck. And then, so there's no more disparity because everyone just has a really bad outcome. On the other hand, making kind of robust coverage available and measuring especially in that, what is happening in the private supplementation. Why is it specifically that? Is it the out-of-pocket cost? Can that be covered in some way under insurance that doesn't have supplementation or in Medicaid?
Well, yeah, but what it makes me think is, on the one hand, it could be that doctors aren't treating Medicaid patients the same way, or on the other hand, it could mean that Medicaid patients don't choose the treatment in the same way, or don't follow up in the same way, or something like that. That they live somewhere where it's hard to get to it, or or their family isn't taking them in for the chemotherapy, or they're in lower quality nursing homes.
Yeah.
So it still leaves a big question as to what the issue is.
Yeah, and I fully acknowledge that. So we lack information on some of those preferences and things like, especially in elderly patients that have an aggressive disease like this, where there's other issues like frailty and other limitations possible. Observation, watchful waiting, limited kind of pared back treatment. Those are very reasonable options, especially for the very elderly. So there's a lot like you were mentioning, there's just a lot of factors that are playing into this treatment. And we looked at this in one angle. Yeah. With the best data we had. Thanks.
Calip, I think